Hi, so welcome back. So we finish headache part 1 and part 2. In part 1, we learned about headache and introduction and what all classification will come, uh, all those things. We got a general idea about headache in the part 1 and part 2 we dealt with secondary headache, right? So different types of secondary headaches. So next comes the final part is primary headache. So the classification, the second part is primary headache. So in primary headache, the most common primary headaches are migraine, tension type headache and cluster headache. So the primary headache, that umbrella term covers the different types of headache like migraine, tension type headache and cluster headache, that is very common. So here you can see this cluster type is the difference between these three. In a simple version is, in cluster type the pain is in and around the eye. So in the cluster type the pain will be in and around the eye, that is retrobulbar. They will tell it as retrobulbar. And in tension type it is a the band type squeezing pain, that is in tension type headache. And in migraine the pain will be there with the nausea and visual changes, visual disturbances, that is sensory nerves are also affected there. So there is a neurological symptoms also you can see, like photophobia, phonophobia, all those things, aversion towards sound, aversion towards light, and on top of that there will be unilateral one-sided headache. This is migraine. So that is one-sided headache is migraine, and band like squeezing pain is tension type, and if the eye is paining then that is a cluster headache. So we'll go in detail to each disease. In that, first one is migraine. So migraine, the second most common cause of headache, afflicts approximately 15% of women and 6% of men over a 1 year period. So here it is a second most common cause of headache, and it will affect more women than men. So 50% of women and 6% of men over a 1 year period. In a year, this much people will get affected newly. So 15% women and 6% men. And it is usually an episodic headache associated with certain features such as sensitivity to light, sound or movement, nausea, vomiting, and often accompanying the headache. So it is an episodic headache. It is associated with certain features, not only headache, along with that there will be sensitivity towards light. They have an aversion towards light, and also sound. They'll tell, just please stop making sound like that. So or movements, any movements, it will aggravate the headache, and also there will be nausea and vomiting along with this headache. So that is migraine. A useful description of migraine is a benign and recurring syndrome of headache associated with other symptoms of neurologic dysfunction in varying admixture. So these are the neurological dysfunctioning, that is photophobia, phonophobia, all those things. So there will be description of migraine is, it's a benign and a recurring syndrome of headache, and it will be associated with other symptoms of neurological dysfunction in varying admixtures. So some people will have this phonophobia, some will have photophobia. It's not compulsory that all the symptoms should be there in that patient. Some symptoms will be there, some won't be there. Migraine can often be recognized by its activators referred to as triggers. Migraine triggers are there. We will go in detail in the coming slides. So there will be some activators for this migraine, that is referred as migraine triggers. And symptoms of migraines are, so you know the migraine, you got an idea about the migraine right now. So there will be unilateral headache, along with that there will be neurological symptoms like photophobia, sensitivity to light, sensitivity to sound, movements, and also along with nausea and vomiting, this headache will come. So there are triggers for migraine. So here first we are seeing about the symptoms of the migraine. So you all know migraine is a unilateral headache. So along with that there will be nausea, photophobia. Photophobia is sensitivity to light, lightheadedness. The people will feel has lightheadedness, and vomiting, and visual disturbances. They can't see clearly during that attack of headache, and vertigo, you know, right? There will be a imbalance stage, and diarrhea. Sometimes the patient will complain of diarrhea also. So these symptoms, not completely it will be there in one patient, some of this will be there along with the headache is the main. The brain of migrainer is particularly sensitive to environmental and sensory stimuli. So that sensory stimuli is, you know, right? So the migraine people are prone for this environmental and sensory stimuli. Migraine prone patients do not habituate easily to the sensory stimuli. Sensory stimuli is the stimulus from the sensory organs. Motor means muscle, and this sensory organs means eyes, ears, nose. So any smell or this bright light or loud noise, all those things, or sometimes even the food will it will take it is not easy for a migrainer, that is migraine patient, to adjust with that. So a new thing. This sensitivity is amplified in females during the menstrual cycle, maybe due to the hormonal changes. So sensory receptors or motor neurons, you know, right? So sensory stimuli means from the sense organs, stimulants from the sense organs, and motor stimuli means from the muscular and all. So the migrainer is particularly sensitive to environmental and sensory stimuli. Migraine prone patients do not habituate easily to a sensory stimuli. So that will have change to a trigger for migraine to happen. So that smell, unpleasant smell or a new smell can trigger the migraine to get migraine fast. So during the menstrual cycle, if you sit in during the clinical practice, you'll experience that during the menstrual cycle, the female will get this sensitivity. It is amplified. The sensitivity will amplified more, and they will get that attack during that ovulation and menstruation period. Headache can be initiated or amplified by various triggers. So now we'll see which all are the triggers that will cause this migraine, including glare, light, that glare, you know, right? So some sounds, and hunger. If the patient is feeling hungry and not having food, then within half an hour they will get that migraine. Excess stress or physical exertion. More physical exertion means again they will get stormy weather or barometric pressure changes. Stormy weather, weather change or barometric pressure changes means barotrauma means it's if you go in higher altitudes in flight and all, if you go, you'll get a closed obstruction in the ears, like that. So that pressure, high altitude pressure changes, that will also trigger this migraine. And hormonal fluctuation during menses. So hormonal changes during the menstrual period or ovulation period. Alcohol or other chemical stimulation, that will also trigger. And lack of or excess sleep. So lack of sleep or excess sleep, both can trigger this migraine. Other afferent stimulations, stimulations can also cause migraine. And bright light, some people will tell after driving in the night they will get migraine. So due to the looking at the bright light, and some people will tell when they will go out and in a sunny day they will get that will be a trigger for migraine. So all these are the triggers for, these are some examples. There are a lot of other triggers also. So these are some common triggers for migraine. So glare, sounds, hunger, excess stress, physical exertion, weather change or barometric pressure changes, hormonal fluctuation during menstruation or ovulation, alcohol or other chemical stimulation, lack of sleep or excess sleep, and other stimulations, and also bright light can trigger a migraine. Knowledge of a patient's susceptibility to specific triggers can be useful in management strategies involving lifestyle adjustments, right? So, if you know these all things will trigger migraine, and if you expose to all these things you will get migraine, then we can tell the patient not to avoid that one. So that is what mean by this one. Knowledge of the patient's susceptibility to specific triggers can be useful in management, in treatment strategies involving lifestyle adjustment. So we have to tell the patient at this time you have to go to bed, and this particular time you have to take food. All those things we have to advise to the patient, and that lifestyle adjustment itself will help the patient to avoid this or prevent migraine. Pathogenesis. I know this is a little difficult, but just go through it. You'll understand. You know all these pathways in the brain and all, right? So this is mainly because of some neurotransmitters and some chemicals that is secreted in our brain. So these are the factors which is causing migraine. So this mainly because of the blood vessels, dilation and constriction of the blood vessels. So the sensory sensitivity that is characteristics of migraine is probably due to dysfunction of monoaminergic sensory control system located in the brainstem and thalamus. So there are some control system that will control this production or this activity of this neurotransmitters inside or neurochemicals inside our brain, that is like serotonin, dopamine, all those things. Some chemicals are there that will secrete during our emotions, or that will control our activities, emotion, stress, or also for sleep, awake, yawning. All those things are controlled by these neurotransmitters or neurochemicals which is secreted inside our brain. So that is controlled by this monoaminergic sensory control system. So this system is located in the brainstem and thalamus. So sensory sensitivity that we already saw in the beginning, right? So that is characteristic of migraine is probably due to that sensitivity is due to the dysfunction of this monoaminergic sensory control system, which is controlling the neurotransmitters or neuropeptides or neurochemicals inside our brain. So because of the dysfunction of this system, they are getting sensory sensitivity, and that will lead to migraine. So this control system is situated in our brainstem and thalamus. Brainstem pathways that modulate sensory input. So there are some pathways, there is afferent and afferent pathways in our brain. So one pathway that will all these are hypotheses about the migraine. So the one pathway I am discussing here. So the key pathway for pain in migraine is the trigeminal-vascular pathway system, or that will get the input from the meningeal vessels. This is inside our brain. So the key pathway for pain in migraine is trigeminal-vascular input from the meningeal vessel. So meningeal blood vessels are there, middle meningeal blood vessels are there. From there, that will get the pathway, the pain receptors will come to the trigeminal-vascular pathway, which passes through the trigeminal ganglion and synapses on the second order neurons in the trigeminocervical complex, that is TCC. I will show the picture, then you will get an idea. So it is mainly from the meningeal vessels. So middle meningeal vessels are there. So it is from the pain is from the meningeal vessels, and it will passes through the trigeminal ganglion, and it will get synapses on the second order neuron in the trigeminocervical complex, that is TCC. These neurons in turn project in the quintothalamic tract, and after discussating in the brainstem, synapse on neurons in the thalamus. So from there, the another tract will start, that is quintothalamic tract, and after decussating in the brainstem, it will decussating through the brainstem, and in the thalamus it will synapse on the neurons. Important modulation of the trigeminal-vascular nociceptive input comes from the dorsal rampant nucleus locus coeruleus and nucleus rampant magnus. I will show that. So this is the middle meningeal artery. So you can see here, this is the middle meningeal artery, and this is only giving supply to the artery of trigeminal nerve ganglion also. So here you can see from the meningeal vessels, it will go through the trigeminal ganglion, and from there you can see all this dorsal rampant nucleus, locus coeruleus, and all this raphe are there here, and it will go to the thalamus. So from the blood vessels to the trigeminal ganglion, and it will get, that is the second order neurons of the trigeminal ganglion. It will get synapses there, and then it will go to this nucleuses in the brainstem, and from there it will go to thalamus. So that is what we discussed here. Okay, so the key pathway for the pain in migraine is the trigeminal-vascular input from the meningeal vessels, which passes through the meningeal ganglion that we saw in the picture, and it synapses on second order neurons in the trigemino-cervical complex, and that is there in the after this trigeminal ganglion, and these neurons in turn project in the another tract, that is quintothalamic tract, and it will go to the brainstem, and then it will go through the thalamus, and in between the modulator for this trigeminal vascular nociceptive input, that is nociceptive is pain receptors, right? So input comes from this nucleuses present in the brainstem. So from here, this is the meningeal artery. From here, this will go through this input will go through the trigeminal ganglion. From there to the through the another tract, it will go via the brainstem to the thalamus, and here you can see these are the modulation input from dorsal rampant nucleus, that is nociceptive pain receptors, and it will give input, and it will again go to thalamus. So from meningeal vessels, trigeminal ganglion, and from there to this brainstem, and then to the thalamus. So that is the pathway. Activation of the cells in the trigeminal nucleus results in the release of vasoactive neuropeptides, particularly CGRP, that is calcitonin gene related peptide, at vascular terminations of the trigeminal nerve and within the trigeminal nucleus. CGRP receptor antagonists have now been shown to be effective in acute treatment of migraine. So activation of these cells in the trigeminal nucleus results in the release of neuropeptides, that particularly the CGRP. So this activation of cells in the nucleus, trigeminal nucleus, in the trigeminal ganglions, so that cells got activated, and it will release a vasoactive. Vasoactive means that will act in the vessels. So blood vessels, neuropeptides are released, and that especially in the migraine, it is CGRP. So that is calcitonin gene related peptide. So that will cause at vascular termination of the trigeminal nerve. That means vascular termination, vascular end of the trigeminal nerve, and within the trigeminal nucleus also. So that will cause the pain, right? So this antagonist means opposite of this receptor, will act as effective in acute treatment of the migraine. So when this goes through this pathway, this activation of that cells in the trigeminal nucleus will secrete some neuropeptides, that is the CGRP. So this CGRP will go to the vascular termination, that is vascular end of the trigeminal nerves, and there will be migraine. So at that time, if we give the CGRP receptor antagonist, means the against of this opposite of this receptors, then that is a effective treatment in migraine, right? So that will reduce the production of this, and it will reduce the pain. So that is one pathogenesis. Pathogenesis means one path of forming this migraine. So another hypothesis is regarding the dopamine. Data also support a role of dopamine in the pathophysiology of migraine. Dopamines are also this protein secreted from these neurons. So most migraine symptoms can be induced by dopaminergic stimulation. So if we give dopamine is the cause of this. It has a lot of function in our body also, body system also, renal, cardiovascular and all. But the main function of dopamine is giving the satisfaction, that pleasure. If you are if you have a craving for a food, and at that time this if we are making that food, that smell comes, the dopamine will start secreting more, and when you have that one, that satisfaction you will get because of this chemical which is produced, this hormone produced in our brain. So that is dopamine. So that is also having a an action in this migraine production. So most migraine symptoms can be induced by dopaminergic stimulation. If you give dopamine, this sensitivity and all will start seeing in a person. So moreover, there is a dopamine receptor hypersensitivity in migraineurs. So at demonstrated by the induction of yawning, nausea, vomiting, hypotension and other symptoms of a migraine attack by dopaminergic agonist at doses that do not affect non-migraineurs. So it is having a hypersensitivity towards dopamine receptors. So the migraine patient will have a hypersensitivity towards that one. That, for example, yawning, nausea, vomiting, hypotension and all these things can be seen in a migraine patient if you give this dopamine receptors. So, dopamine receptor antagonists are effective therapeutic agent in migraine. So, we can give the opposite of this dopamine hormone also as a effective treatment for migraine. So, these two are the pathogenesis or pathology mentioned for this, are hypothesis. So, hypothesis mentioned for migraine. So, first one is due to through that pathway, right? So, trigeminal input from the meningeal vessel. So this pathway, brainstem pathway that modulates the sensory input is from the meningeal vessels. There will be a trigger or a input to the which passes through the trigeminal ganglion, and then it will get synapses with the second order neurons, so trigeminal cervical complex, and then it will reach the brainstem and to the thalamus, and in between there are some nucleuses it passes through in the brainstem, and that you can see here, from here trigeminal ganglion and then brainstem and through the thalamus, and these will activate the cells and produces neuropeptide, that is CGRP, and these will trigger the pain. And if we give the antagonist of this, that is an effective treatment. And the next hypothesis is about the dopamine receptors. So these migraine patients will be sensitive to hypersensitive to this dopamine receptors, so that will cause trigger to migraine. And if we give against of this dopamine, then it will reduce the migraine. Will it's a effective therapeutic agent for dopamine receptor antagonist, is a therapeutic agent for this migraine. So next comes the diagnosis and clinical features that they are telling. This is the table showing this diagnostic criteria for migraine headache, and at least two of the following features should be there. So repeated attacks of headache lasting 4 to 72 hours in patients with a normal physical examination, no other reasonable cause for headache, and unilateral pain, one-sided pain, throbbing pain, and aggravation by movement. If they walk or move, it will increase, or moderate or severe intensity. At least two of this should be there, and also plus at least one of the following feature, that is nausea or vomiting, photophobia and phonophobia. Any one of the features should also be there, then we can confirm that as a migraine. So physical examination should be done. Any other secondary headache reasons and all we have to rule out. After that, nothing is there, and only unilateral headache with a throbbing pain, and or else it will aggravate with moving, photophobia is there, phonophobia is there, or nausea and vomiting is there, then we have to confirm that as migraine. A high index of suspicion is required to diagnose migraine. The migraine aura, consisting of visual disturbance with flashing lights of zigzag light moving across the visual field or of other neurologic symptoms, is reported in only 20 to 25% of patients. So migraine auras are there. Migraine auras means some visual disturbances the patient will get before getting the headache. So that is a this thing for diagnosis, but it is seen only in 20 to 25% of the patient. So it's a flashing of light will come, or in the visual field. Visual field means the side vision, what all things we can see. So the side and all, there will get a zigzag lines moving across the visual field, or they will get a flash of light coming and going like that. So that is a migraine aura, and it is seen in 20 to 25% of patients only. A headache diary can often be helpful in making the diagnosis. This is also helpful in assessing disability and frequency of treatment for acute attacks. So that is for the we will ask the patient to write when you are getting and for how long it is there. So how frequent it is coming. So by seeing that, we can go for a particular treatment. Patients with episodes of migraine that occur daily or near daily are considered to have a chronic migraine. If they are getting daily this migraine attack or near daily, alternate days and all, then we can tell them as chronic migraine. So next comes the treatment. Treatment, as we discussed before during the triggers, right? If you know the trigger, we have to ask the patient to avoid that trigger. So that is a lifestyle adjustment. So patient education is an important aspect of migraine management. It is helpful to patient to understand that migraine is an inherited tendency to headache, that migraine can be modified and controlled by lifestyle adjustments and medications. But it cannot be eradicated, and that except in some occasions in women on oral estrogens or contraceptives, migraine is not associated with serious or life-threatening illness. So we have to first educate people. We have to give the patient education that it's like a modify. You can go with this with your lifestyle adjustments or medications, and it cannot be eradicated completely. We have to educate the patient like that, and also only if it is because of some oral contraceptives or estrogen. Other than that, we can't eradicate this migraine. And also it's not a life-threatening disease or a serious illness. That first we have to educate the patient. Then it can be often managed to some degree by a variety of non-pharmacological approach. That is what we discussed before. The triggers should be avoided. So most patients benefits by the identification and avoidance of specific headache triggers. Stress, this bright light, all those things we can ask, hunger, proper sleep pattern, all these things we can advise the patient. A regulated lifestyle is helpful, including a healthful diet, regular exercise, regular sleep patterns, avoidance of excess caffeine and alcohol, and avoidance of acute changes in stress levels. So regulated lifestyle, you have to healthful diet and a proper timing of the diet, and regular exercise and regular sleep patterns, and avoidance of excess caffeine, coffee and all we have to cut down, and alcohol also, and avoidance of acute changes in the stress levels. All these things will help the patient. And next, medicines we can give NSAIDs, non-steroidal anti-inflammatory drugs can be given. Then stimulation of 5-HT1B per 1 day receptors can stop an acute migraine attacks. That is in the that serotonin 5-HT. So that neurochemicals can stop this stimulation of these neurochemicals can stop a production of these neurochemicals can stop this acute migraine attack. For that we can give ergotamine and dihydroergotamine receptor antagonist can be given. Agonist can be given, and the fastest acting non-parental anti-migraine therapies, that is nasal formulation. So migranal, somic nasal, or sumatriptan, all these things can be given through the nose, so nasal formulations, and also through the parental administration of these things can also be given. Dihydroergotamine and sumatriptan is that is approved by the FDA, so that can also give in through the oral route, that is parenteral route. So these medicines can be given for migraine therapy. So non-steroidal anti-inflammatory drugs and this receptors, agonist of this receptors, and also nasal formulations like migranal, somic nasal, all those things, and also that can be given orally also. So these are the treatment for migraine. So in the primary headache, so these are the what is the presentation of migraine, and what all symptoms you can see along with headache, and what all triggers that will trigger migraine, that is also we discuss, and also the pathogenesis, the pathway of this migraine, and the treatment. So this is all about the migraine. So that is a primary headache. So first one in primary headache. The second type of primary headache is tension type headache. So the tension type headache, clinical features of this tension type headaches are: the term tension type headache is commonly used to describe a chronic head pain syndrome characterized by bilateral tight band-like discomfort. So here we'll get a band-like tight bilateral, so both the sides you will get, so bilateral tight band like discomfort the patient will feel. So this is a chronic type also. The pain typically builds slowly, fluctuates in severity, and may persist more or less continuously for many days. So it will start slowly and then it will go severe, then it will come down. So it will fluctuate in the severity. Sometimes it will be very severe, sometimes it will come down, and it may persist more or less continuously for many days. We can't tell. So it will be there for this many days. This severity will change. The headache may be episodic or chronic, present more than 15 days per month. So it can be for some period, then it will be normal, then it will be there for some more time. So it's like a episodic or a chronic. So it will be present for more than 15 days per month. In a month, more than 15 days, the patient will have this type of pain. So it is like a band like discomfort with bilateral, both the sides it will be there. So these are the areas you can see in this picture. So these are the areas of pain for this tension type headache. A useful clinical approach is to diagnose this tension type headache in patients whose headaches are completely without accompanying features such as nausea, vomiting, photophobia, phonophobia, osmophobia, dropping, and aggravation with movement. So these symptoms won't be there with this type of tension type of headache. Only that band like headache will be there, and this episodic more than 15 days will be present, and it will start with slowly and then it will go to severe, then also it will come down, but it won't be accompanied by any one of these symptoms, that is nausea, vomiting, photophobia, phonophobia. Nothing will be there in case of tension type headache, and this can be seen in migraine. And such an approach neatly separates migraine, which has one or more of these features and is the main differential diagnosis from tension type headache. So these features are not seen in a tension type headache, and it is seen in migraine. So this is a main differential diagnosis for migraine and tension type headache. And pathophysiology of tension type headache, this is incompletely understood, so it's not known, and it seems like the tension type headache is due to the primary disorder of central nervous system pain modulation alone. So there is a problem in the pain modulation system, the central nervous system. It may be due to it is a primary disorder for tension type headache, and the pathophysiology is not known. The name tension type headache implies that pain is a product of nervous tension, but there is no clear evidence for tension as an etiology. So by the term we will think, okay, it is because of the tension of the patient, but it is not like that. The name tension type headache implies that the pain is a product of nervous tension. It is due to the nervous tension the patient is getting this tension type headache, but there is no clear evidence for the tension as an etiology. As a cause, a tension is not mentioned. We are not getting any evidence like that, but it is mainly due to the tension of the nervous tension causing this tension type headache. And the treatment for this tension type headache is pain of tension type headache can generally be managed with simple analgesics like acetaminophen, aspirin, or any other this anti-inflammatory drugs. So they are non-steroidal anti-inflammatory drugs can be given for the management of this pain. So analgesics are normally given. So that is tension type headache. So tension type headache is band like a headache, and it can be seen more than 15 days in a per month, and also it can be differentiated by differential diagnosis from migraine is that accompanying symptoms are not seen in this tension type headache like photophobia, nausea, vomiting, anything else can be seen cannot be seen in this tension type headache. And the pathophysiology is not known, it is not clear, and it is mainly because of the central nervous system, this pain modulator problem is there, and also it's mainly because of the tension of the nerves and not an etiology as tension. So next, the third one is that migraine is over, tension type headache is over, and the third one is cluster headache. So that will come under trigeminal autonomic cephalalgias, including cluster headache. That is a group of headache, trigeminal autonomic cephalalgias. So this TACs, that is trigeminal autonomic cephalalgias, describe a grouping of primary headaches, including cluster headache, paroxysmal hemicrania, and short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing, and also short-lasting unilateral neuralgiform headache attacks with cranial autonomic system (CNS). So cranial autonomic symptoms. These are a group of headache. In that, cluster headache will also come. That is, in TACs, this cluster headache will also come. These all will come under primary headache only. So we are mainly concentrating in cluster headache only. So TACs are characterized by relatively short-lasting attacks of head pain associated with cranial autonomic symptoms such as lacrimation, conjunctival ingestion, or nasal congestion. So these are trigeminal nerve, you know, right? The supply of the trigeminal nerve. So these symptoms will also, along with the headache, there will be lacrimation, conjunctival ingestion, conjunctival symptom, and also nasal congestion will be there. So that is the peculiarity of this TACs. So in cluster headache also we can see all those things. So we are going to the cluster headache. Severe and may occur more than once a day. So cluster headache is a rare form of primary headache with a population frequency of approximately 0.1%. So it's a primary headache. And the pain is deep, usually retroorbital. Retroorbital means behind the orbit. So the pain is very deep and it is retroorbital and often excruciating, often increases in intensity, non-fluctuating, and explosive in quality. So it will be a severe pain and it won't fluctuate. It will be severe pain always. A core feature of cluster headache is periodicity. That is why cluster headache, that periodicity will be there for this cluster headache. And at least one of the daily attacks of pain recurs at about the same hour each day for duration of a cluster bout. So at least one of the daily attacks of the pain recurs at about the same hour each day. So you can see, we will understand from the next sentence. The typical cluster headache patient has daily bouts of 1 or 2 attacks of relatively short duration, unilateral pain for 8 to 10 weeks a year. This is usually followed by a pain-free interval that averages a little less than 1 year. So this cluster means a group, right? So some time it will be there, then it is normal. That's why it is known as cluster headache. A typical cluster headache patient has a daily bouts of 1 or 2 attacks. So 1 or 2 times in a day they will get this attack, and it is for a short duration. It will be for a small duration, and there will be unilateral pain, only one eye. one eye there will be pain, because we told this cluster headache will be seen retrobulbar. Behind the orbit you will get this headache, and it will be there. So one side only it will be there, and it will be there for 8 to 10 weeks in a year. So in between there won't be any attack. That will be a normal pain-free interval. So that's why it is known as cluster headache. So 1 or 2 times in a day they will get, it will be there for some weeks, and again for some time it won't be there, again it will come. So that's a peculiarity of this cluster headache, and it will be unilateral, and it is a severe pain, and it will be seen retroorbital. Retroorbital means behind the orbit, behind the eye you will get that pain, and it's very deep pain and explosive in quality. So you have to understand the severity of that pain. Cluster headache is characterized as chronic when there is no significant period of sustained remission. It's mostly it's chronic condition, and patients are generally perfectly well between the episodes. In between the episodes, that is the pain-free time, the patients will be perfectly all right. And the onset is nocturnal. It will be during the night in about 50% of the patients. The pain will be there in 50%, half of the patient it will be there in the night time, and men are affected 3 times more often than women. So men are affected 3 times more than women, but in migraine we told it's affected more in women. So cluster headache is seen more in men. So patients with cluster headache tend to move about during attacks. So they will move because of the pain. They will become restless, pacing, rocking, or rubbing their head for relief. Some may even become aggressive during the attack. So because of the severity of the pain, they will be moving around, pacing and rocking, and also they will be massaging hardly their head to get relief, and some even more aggressive during the attacks. And that is against the migraine, right? So in migraine the patient will be sitting in a place. They don't want to move. If they move, it will aggravate. So they will be calmly motionless, remain motionless during their attacks. But in cluster headache it is opposite. They will be pacing and rocking or rubbing their head, or they will be aggressive during these attacks. So that's the difference between cluster and migraine. And cluster headache is associated with ipsilateral symptoms of cranial parasympathetic autonomic activation, conjunctival ingestion or lacrimation, rhinorrhea. Rhinorrhea means a running nose or nasal congestion, or a cranial symptomatic dysfunction such as ptosis. Ptosis means drooping of eyelids. So it can be associated with these symptoms also, because TAC is we told, right? So there it is associated with this type of headache is associated with this lacrimation or ptosis of the eyelid, or there will be rhinorrhea, running nose, or nasal congestion. So this sympathetic deficit is peripheral and likely to be due to the parasympathetic activation with injury to the ascending sympathetic fiber surrounding a dilated carotid artery as it passes into the cranial cavity. So this symptoms, associated symptoms, is mainly due to the parasympathetic activation. So parasympathetic activation with injury to ascending sympathetic. Ascending means that is going. Ascending sympathetic fibers surrounding a dilated carotid artery, and it passes into the cranial system. We told, right? It is associated with this neurological symptoms like this conjunctival ingestion or lacrimation, rhinorrhea, or cranial symptoms like ptosis. All this is because of the parasympathetic activation along with this headache. When present, photophobia and phonophobia are far more likely to be unilateral and on the same side of the pain rather than bilateral as seen in migraine. If it is associated with this, sometimes there will be photophobia and phonophobia, but it will be unilateral in cluster headache, but it will be bilateral in case of migraine. That is a differential diagnosis between cluster headache and migraine if they are having these two symptoms as common for cluster headache and migraine. So photophobia and phonophobia is sometimes present because of this neurological involvement. And if it is there, but in what is the difference between photophobia and phonophobia in cluster headache and in migraine is, in cluster headache it is unilateral, and in migraine it will be bilateral, it will be seen in both the sides. So this phenomena of unilateral photophobia or phonophobia is the characteristic of TACs. Cluster headache is likely to be a disorder involving central pacemaker neurons in the region of posterior hypothalamus. So because of this involvement, there will be unilateral photophobia and phonophobia. So treatment for this cluster type headaches are, the most satisfactory treatment is the administration of drugs to prevent the cluster attack until the bout is over. So you have to give the drugs to prevent the cluster attacks until the bout is over. And the cluster headache attacks peaks rapidly, and thus a treatment with quick onset is required. So it will peak, or the pain will become peak rapidly, so they have to give a medicine immediately. And many patients with acute cluster headache respond very well to oxygen inhalation. If we give oxygen inhalation, the patient is responding very good during this cluster headache. So this should be given as 100% oxygen at 10 to 12 liter per minute for 15 to 20 minutes. That oxygen should be given. So it appears that high flow and high oxygen content are important. The choice of a preventive treatment in cluster headache depends in part on the length of the bout. So it depends on the treatment. The choice of treatment depends on the length of that bout, how long it is there in patient. So it is different in each patient. So they are telling for their treatment it needs needs to know which treatment should be chosen, but depends on the length of the bout. So the patient with the long bouts or those with chronic cluster headache require medicines that are safe when taken for long periods. So if it is a chronic patient, we have to give the medicine for a long time. So that we have to take safe medicine should be given to those patients during that time. And for patients with the relatively short bouts, limited course of oral glucocorticoids is enough. So if it is with a small short bouts, means we have to give only glucocorticoids. So that's a treatment for cluster headache. So during the acute condition, we can give oxygen. High oxygen content will reduce that reduce this attack. And also as for a treatment, we have to first see whether it is a long bout or a short bout. For long bout means the disease is chronic, so we have to give the medicine also for a longer time. So we have to choose a safe medicine. And if it's a shorter bout, we can give glucocorticoids for those short bout patient. So this is a cluster type headache. So these are three types of primary headache: migraine, a tension type headache, TTH, and last one is cluster headache. Hope you all understood this three types of primary headache. Thank you.